you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
Okay, so fantastic. That was some amazing teaching. Not the best I've ever heard, but for an Australian, that was incredible. So we're going to end with DVT, 5 quick minutes of DVT. This is a scan that I think is not that tough to do, but it seems like a lot of people are scared of it. You take a look, everything looks compressible, you think no DVT, but then you end up getting a study from radiology because you're just not quite comfortable, you think you're going to miss it. And I felt that same way until a study by Tim Jang from UCLA, where he took 40-something providers, heterogeneous group, residents, interns, different specialties, 10 minutes at the bedside. He taught them two-point compression for DVT. They enrolled 199 patients. They found 40-something DVTs prospectively. They did the scan and radiology did the scan. They missed 0 of these DVTs. And this is after 10 minutes of bedside education. That was the study that gave me the confidence to really do this. And so 10 minutes at the bedside for Americans, Australians, 2 minutes. You guys should be good. So Mike's going to show you how to do this. Actually, we're going to show on both sides. So the first place they started was the femoral vein, common femoral vein. And the clots tend to happen at the branching points. So we're going to look for the takeoff of the saphenous. It's usually pretty proximal. If you're not getting somewhat uncomfortable about how high you're getting, it's usually a little higher. So you can see the takeoff of the saphenous on the left side there, just coming off. So we compress there, see no clot. Great, no DVT. To be a little more, in the Jank study, that's all they did. To be a little more conservative, you go down several centimeters, look at other couple branching points, common femoral and superficial femoral vein as well. The next point is the popliteal vein. It's right behind the knee. That's usually not a tough landmark to find. You find the knee, you go right behind it, and it's going to be on top, right? The pop is on top, the popliteal vein on top of the popliteal artery, so more superficial. So you see on the right side there, the compressing of the vein's completely disappearing, and you can go up a few centimeters from there as well to make sure it's all compressible. And that's it. In the study, that's what they did, and they found all of those in the prospective group of 199 patients and over 40 DVTs. It's not a really tough scan to do.
Okay, so there's some controversy here. This recent study said that we could be missing up to 6% of DVTs just looking in these 2 spots. Also, most of us who do this go a little further down from the common femoral vein and a little up from the popliteal. We also do some things like augmentation and pulse wave Doppler occasionally, looking for proximal clots. The Jang study I mentioned supports just the 2 points, but when he wrote the chapter in our ebook, even he talked about going a little distal and a little proximal. So what's my practice? Well, low suspicion, ambulatory patients, I do this 2 point just like I described. Sicker patient, higher suspicion, maybe I suspect a proximal iliac clot or something like that. Then I add some other maneuvers. So to clear all this up, I've asked Mike Stone to go over his approach to this, which is more complex if you want to know how to do the more robust exam. He wrote a great ebook about it that's free in the iTunes bookstore. Download that, read it, then we'll have Stone demonstrate on the podcast very soon.
So there are lots of other studies of point-of-care providers doing this as well, and they all have really good results. I think we can do this. So a quiz. Did it already advance on me? Let's see. Maybe stuck. Here we go. What's the diagnosis?
DVT.
DVT, great, perfect. So you can see the artery on the left, right here, vein right here, and watch them as we compress. Watch that video one more time. That vein on the bottom right does not compress. That's a DVT, and you can see the arteries start to compress a little bit, so you know you're pressing hard enough to actually compress it. So what's your diagnosis here? Yeah.
There's still clot in that vein.
Yeah, that's kind of scary. You see that clot just flopping around there. And to be honest, I usually don't use color. I usually don't do a lot of augmentation like this, just straight compression. But here you can see the clot there without even doing any compression. With augmentation, that's kind of floating around. What would you guys do in this case?
Probably not send them home. Have a chat with interventional, see if they want to put in a filter, see if one of the vascular surgeons wants to take it out. Keep a close eye on them and anticoagulate them probably. I don't think there's a right answer with lots of evidence.
I just knock it loose.
Just squeeze it a bit, yeah. Then you get
it out of the way.
It gets more exciting, doesn't it?
Yeah, that's
I think
tough.
We should move on to the next bit.
When you see
I
one
think we're pretty much
flopping around.
out of time for this.
All right, last thing, James. What's this? Yeah, go ahead.
Baker's cyst.
So this is actually, I'll give you a hint, watch it again. There's some color flow in it. So I've seen this mistake made a few times. Swollen, red, painful. You look and think that maybe it was a clot or DVT, but this is a swollen lymph node in the differential diagnosis. And you know there's no artery around there, so this is not the femoral vein, even though you're in that area. Sorry, I'm hurrying now. Last thing, what is this? It's in the differential diagnosis, swollen, tender in that area. What does that look like to you?
That has a cobblestone appearance. I mean, it looks like there's infection, cellulitis.
Yeah, exactly. This is not really a trick question, but this is in the differential, and I see this occasionally when scanning for DVT. Great.
I don't need that. Thank you. All right. Thank you very much. Thank you. All right. The next section is I get to teach you something. And I've got 7 minutes, but I'm going to try and do it in 5. Lewis, you're going to...
Yep, on the
what
number.
we're going to do is we're going to build... Can each pair have a set of Play-Doh, please? All right? So you guys, I want you to build a heart. You two, I want you to build a heart. You guys, I want you to build a heart. All right, and I'm going to build one too. You supervise them, make sure they do it right. And I'm going to build one. We also need a big knife. We got knives? Okay.
Yep, Tom and Kim.
And we need one patient, one medical student up here, with a young man again. All right, so if you guys don't mind doing it there. All right, what we're going to do first... Oh, is someone going to help me? Nixon around? I don't know.
Yep.
Anyone? All right. Good. All right. What we're going to do first is we're going to get the... Jump up, Aiden. All right.
Oh, it's sticky. Guys. Yep.
We're going to get the left ventricle first. Okay, and when you're trying to understand heart anatomy, it's quite good if you do it bit by bit. The left ventricle sits like this. And if you're looking at it with ultrasound, you're going to be taking a cross-section through that. And so if you're doing a parasternal short axis, which is from here, it's going to look like a round thing, right? You've got an ice cream cone. If you're doing a parasternal long thing, it's going to look long. Okay, so left ventricle, easy. Right ventricle, please. Excellent. We're going to get... Now, the right ventricle, can you hold that for me, Aiden? It's just like the left, except I've cut this cup in half, okay? And so what we're going to do is we are going to fold the right ventricle around the left ventricle. Okay? See that? We film that? There we are.
Because otherwise you're going to get confused.
So your cross-section through the parasternal short should look a bit like that. Okay? And we all know that the heart sits like this with the right ventricle in front, because when you get stabbed through your right ventricle first. All right. Now we're going to go for a left atrium. That's pretty easy. That goes on there. Now, I'm going to get one of you guys to help me. Can you roll that into a ball? Okay, the aorta, not into a ball, into a long skinny thing. That's the aorta. Everyone, your red ball into an aorta. Okay, so we're getting there. Now, the aorta comes out just towards the front. Okay, so it comes out here. Thank you very much. Ooh, that's a chunky one, isn't it? All right. American aorta, we know about this semen. All right, so there's the aorta coming off there. Now we're going to put on a right ventricle, which sort of squeezes in like that. Okay, so now you can imagine if you're taking an apical 4-chamber and looking from here, you're going to see that 4-chamber view. That wasn't predictable. All right, and this last thing I want made into a Y shape. All right, so, yep, make that into a Y.
Comes down. Yep,
oh, dear.
You got to do the, Yep.
All right, so a Y shape. Here, let's show them what we're doing.
Yep, easiest way.
Okay, that's perfect. And this is the pulmonary trunk, and that is a chunky one. That comes out, loops under that aorta like that, and sits like that. So this is your finished heart. Okay? Jeez, that's 1 minute. Okay, so what we got is that sitting in your chest, and you've got to find windows. Lung and bone get in the way. You've got to find that little window in here, move up and down. You can be my holder. So hold it as it would be in your chest. Okay, lung and bone get in the way. You've got to search for that little spot for the parasternal views. And you're going to take a view like that, which is your parasternal long, and you're going to take a view like that, it's your parasternal short. Then you're going to come out for the apical 4-chamber and look from here.
This one up.
Okay, and if you want to see the 5-chamber, you angle up slightly so you can see the aorta coming off. And subcostal looks from here. Now, how are we going with our hearts, guys?
Okay. Good.
That's beautiful. All right, now the first thing I'm going to do is I'm going to take one and cut it in half. Okay, so what I'm going to try and do, if we can get one of our models on here and look at your heart in the parasternal long axis, that'd be great. So I'm going to cut what I think is the parasternal long through here.
Okay.
And we're going to see if it looks like what comes on the screen. All right. Okay, so what we can see here is we can see the left ventricle. Okay, where's that pointer? Anyone got a pointer?
No, I must have lost it. Sorry.
Do you mind pointing it out? Go on. I'm sure you know what the left ventricle is. All right, so we've got the left ventricle. These guys are great. Okay, we got the left ventricle. We got the right ventricle, which you see at the front, that thinner one. We got the left atrium, okay? And we got the aortic root coming out here. And it's all there in that, and they look sort of the same. Okay,
Fantastic. That's worth a clap. Well done, John. Beautiful work. Woo-hoo!
All right, so now I'm going to use this knife again. Silence.
Let's look at...
Parasternal short.
Let's do my
Okay.
contribution there. What's in your hand there?
All right, parasternal short. Don't worry, sir, trust me.
And then he puts it up here because he always wears it on his true American style. Well, nice. Slice it down.
Move your hands. Okay, parasternal short. We can get you to look after that, far away. Thank you. Okay, parasternal short. Where's our camera? I'll try and find you, it's all right. Okay, so we've got parasternal short here. Which way are we going? That's how it matches. And we've got a round left ventricle. Can you point to the left ventricle? There we go. And we've got a little crescent-shaped right ventricle there. Okay, parasternal short. We might go a bit up to the aortic valve, and maybe, just maybe, we'll see the aortic valve in the middle. There, the red. We'll see the right ventricular outflow tract on top of that, with a little bit of right atrium down there. Okay, that's the pale blue. And posterior, the left atrium. So this is something I use with teaching in small groups. We make Play-Doh hearts, we have a look, we cut it up, and then you can sort of understand how the views get made. That's how I teach normal heart views. Thank you. All right, we're on to the next bit. That's you guys are going to teach us something. Oh, they mean business.
Perfect. So I want to talk to you guys about ultrasound and pulmonary embolus. And I'm going to talk fast because all of you have expected it in the first place, and also because I want to teach you a lot. And I have 7 minutes to do this, so I'll try to do it in 12. So we're going to talk about ultrasound and pulmonary embolus. And the reason I want to talk about this is because I recently found out that in the United States, about less than 10% of the patients that we actually CT for PE actually have PE. That's a ton of patients that we CT. In fact, that's 9 out of the 10 patients that we CT probably didn't need that CT, meaning they didn't actually have a PE. That's a lot of radiation exposure, that's a lot of cost, and it's a lot of risk associated with those patients. Now, I didn't really realize that ultrasound could be so beneficial until I recently read this article in Chest. This was an article that was released in October of 2013 by a group in Italy. And what they did was they took a bunch of patients that presented to the emergency department, 350 of them to be exact, and they said, all right, look, if you have a positive D-dimer with a low well score, or if you just have a high well score at all, we're going to do something called a multi-organ ultrasound on you to see if you have an acute PE. And that means DVT scan, lung scan, and ultrasound scan with the ultrasound machine. And they were actually able, doing this, to reduce their CT utilization by greater than 50%. And that's pretty impressive. So I want to talk to you today about how they actually did that. This is the actual study these are the study results. And they were able to rule out, without a doubt, 100% sensitivity, they were able to rule out PE if they had a negative multi-organ ultrasound and the patient had an alternative diagnosis.
Yes, we know. This doesn't always mean PE. Mike's talking about a patient with a high pretest probability, in which case this has a positive likelihood ratio of 12. We're talking quickly about fine points. Cut us some slack.
Found on ultrasound. In addition to that, they also used ultrasound to help diagnose PE. So some of these positive likelihood ratios, pretty impressive. 15 for lung ultrasound, 21.7 for vein ultrasound, and not too shabby with heart at 3.6 also. So let's get to it. Let's talk about these. Lung ultrasound, here's what you're looking for. Now this is what they're actually trying to find is a subpleural consolidation. Subpleural consolidation is basically a wedge infarct, and it's coming off the pleural line. That's why they call it subpleural. And it's just this wedge infarct. So this is the area of lung that's not getting blood because the clot is going to that area of lung. Really easy to see. Here's a live image of it. This is a subpleural infarct right here. Voila, done. Patient has a PE. DVT scanning, just talked about it, not complicated. You find the femoral vein, you push down on it, you compress. If it doesn't compress, the patient has a DVT. Why not just go ahead and treat him, right? Same treatment as with PE. Finally, cardiac ultrasound. There's the short axis view, right? That can help you diagnose patients who have right ventricular overload, flattening of the septum. Here we see a normal short axis where you have a round left ventricle and a normal sized right ventricle. There's no flattening of the septum here, as opposed to this one where there's clear flattening of the septum. They've got right ventricular overload because the clot in their pulmonary artery is causing a backup of pressure in their right ventricle. The apical four-chamber is helpful, right? This is a normal apical four-chamber. There's a normal-sized RV. It doesn't appear bigger than the LV. When you're doing this, sometimes you'll see something like this. This is pretty clear, right? There's a Gumby in the right atrium that's waiting to pop its way through and go into the lungs. And maybe this person's already had a PE. This is somebody I think you can fairly clearly make the diagnosis. But what we're looking for on the apical four-chamber is we're looking for signs of right ventricular failure, like in this video. Apparently my video's not working. I was worried this was going to happen. So in addition, I've prepared something else. I thought maybe we could create a human heart. So if I can just get some help from our contestants here, if you guys can just come up. You're a pretty tall guy, right? You are now the septum. We're going to do an apical four-chamber here. So stand right here, hands in the sky. Thank you. You're pretty tall too. How about we make you the right ventricle here? So right ventricle's on this side of the screen. Just grab his hands for me if you don't mind. And now wait, you guys are married, right? Oh, this is going to be awkward. I changed my mind. You're the septum. Let's switch back around here. There we go. Yep. That could be a little strange. Just go ahead and do that here. Now, if you can just be my left ventricular wall here, thanks. And just you turn around towards him and grab his hands right there. You are my mitral valve, right? So let's see. Hold on. Let me get my left and right. This is left. So you just come back a little bit here. If you can lie down with your legs this way for me, that'd be great. Perfect. Just lie down just like this. And then all the way down. Yeah, get on the ground. There you go. Perfect. And then just go do like this with your hands. Kind of, but more like that right there. Good. Well, yeah, but your valves, your flappy hands, jazz hands. Perfect. Matt, if you'll be my tricuspid valve right here, if you can just get...
Can you put the PowerPoint back up just 1 second? I just want a clarification if I'm going to be the tricuspid valve. So this is a hand, right?
No, that's an arm.
Okay.
It's an arm. Yep. So you be my tricuspid valve there and just do that for me. Okay. So yeah, we're back on the PowerPoint here. So let's practice. We need to do some practice. All the way up in the air. Good. Now I need you guys to do that. Huh? All right, wait. Don't stop. You're doing great. All right. So we're gonna keep going. PowerPoint again, if you don't mind. So now we're going to do some right ventricular failure. So I need the RV free wall to come out a little bit. Here, good. Let's get our hands all the way up in the sky. All right, all the way up. Quit moving for a second. All right, so now during systole, I want you to stick your butt out a little bit more. Okay? And then now you guys are going to get a little closer. See, less awkward, right? See, I'm thinking about you guys. Good. So the left ventricle is a little bit tighter. We've got right ventricular overload, right? So now we've got a big RV. Matt, if you can make your hands come a little bit far apart so there's some tricuspid regurgitation, right? Okay, so now let's try this again. Now, during systole, you move towards her. So there's septal bowing. So the septum moves into the left ventricle now because there's right ventricular overload. So you need a pelvic thrust. Pelvic thrust, good. And you, during systole, you butt thrust. The butt out. Get it out. There you go, good. Yep.
Condition.
Just go straight. Just
Right on.
Stand up, stretch your legs.
If only we could have the vote now, right? Yeah. You've made a good comeback, guys. Let's just get a bit of a vote. The Australian team. Coming back well nicely, guys. US team. Woohoo! Nice comeback. Can everyone, we're locking the doors, no one can leave, but can everyone just stand up? We're having a 30-second break. We're going to rearrange the room, but then we're going to get right into it. Thank you.
Stuff?
What's that?
You need stuff.
Righto, thank you guys, and the doors didn't open. That was fantastic. Righto. Now, we're back onto our US experts again. Matt and Mike, you're going to be up again. Have no idea what they've got in store for us this time. Gentlemen, I hope you're safe. And Matt and Mike are going to talk us through pericardiocentesis.
Great.
All yours, guys.
So we had 5 minutes, now we have 2 minutes. We're a little bit behind. So that's all right. Pericardial tamponade, it's a time-dependent disease. You got to be quick, so we're going to talk really quick and go over this quickly. So our patient, 27-year-old dialysis-dependent kangaroo, comes in short of breath. This is a chronic IV drug-abusing kangaroo. Hepatitis C, could be anything here. Dyspneic, you're going to do a quick lung and heart ultrasound, and this is what you see. Tamponade. This is a clip that I had just a couple weeks ago with a patient. Came in, huge pericardial effusion, compressing that heart. You obviously need a needle in this. Just to make sure you guys know what we're talking about, do you put a needle in this? What do you think? Tamponade? No. There's no compression of that RV free wall at all. Right here you do have a little bit of RV free wall collapse. This is some early tamponade. You all know the definitions of this. If you don't, we've got a podcast that goes over this in detail so you can watch that. But just again, so you know, a little bit of RV collapse right there. A little bit of RA systolic collapse right there. Just to confirm, this is obstructive shock. The IVC dilation kind of goes with that. So how do we do this pericardiocentesis? You know you got to do it here. So you call for a pericardiocentesis tray. If you don't have it, that's fine. Just get a triple lumen catheter kit out. We've got that, I think, somewhere. Did you bring that up, Mike?
I got a needle.
All right, you got your kit, everything, good to go. So what probe are you going to use? So it depends on the patient in the window. What window are you going to use? That also kind of depends. You're going to go where the most fluid is, the biggest pocket. Traditionally, we've talked about doing the subcostal view going through the liver, but really whatever window gives you the biggest pocket you're going to use. When choosing your probe, actually choosing your window, this is the same patient, the peristernal long axis view. And you can see you have a pretty good effusion, room to go in there, but you have so much more on this subcostal view. So we end up going with the subcostal view. We took a look first with the curvilinear probe because you'll get better needle visualization with the curvilinear probe. But we found with our phased array probe, we could really get up in that xiphoid space and get just a couple centimeters away from the actual effusion. If you get a peristernal view with a linear probe, it's acceptable to use that as well if that's where the biggest pocket is. So the probe, the approach is going to depend on your patient, where the pocket is, where the fluid is, and the trade-off between phased array probe, better visualization of the heart, linear and curvilinear, better visualization of the needle. So in this patient, you're going in plane. You're not going out of plane. Mike, show them what happens when you go out of plane. You have you don't have your props. You have to go in plane here. There you go. So the ultrasound beam is here. If you try to go out of plane here, the problem is, so there's in plane. If you try to go out of plane, the problem is you're going to lose your tip occasionally. This is not a time to lose the tip. You see the back of that needle, and it looks like it's in the pericardial sac, but the tip could actually be in the heart itself. So you have to go in plane. When you're going in, you're aspirating. You're going to get blood. This is that patient. This is that patient, and we can barely see the needle, just barely see it coming in because we're using the phased array probe. But again, we're so close to that effusion, that's why we did it. Now we see the tip popping in. We have so much space there that we go in a little bit further to make sure we're actually in the effusion and we're aspirating and we got that blood. You're going to then remove the needle. You're going to remove the syringe. You're going to thread the wire, and this is just an incredibly sexy picture of this wire going into the pericardial effusion. That's amazing. I could watch that over and over again. So now we dilate that up. We put the drain in, we can pull it off, save this patient's life, and we've got a drain in case this is a really rapidly accumulating pericardial effusion as well. We can take some more off later. So what if this is your patient? Look at that tiny bit of space and watch this needle as it's kind of coming in. That is scary to me. You can barely see that needle tip. That could definitely go right into the heart before you saw it. In that case, one thing you can do to make sure that you're in the pericardial space is flush agitated saline and watch it go around the heart in the pericardial sac and not into the heart itself. You confirm that you're actually in the space and now you can dilate. You do not want to dilate up into a ventricle. So agitated saline, needle in plane, and go where the fluid is. That's the main points. So Mike, demonstrate really quick the hand position, what you're going to do.
Pretty simple. I'm just going to get a subcostal window here, say, assuming that's the most amount of fluid I see. I'm going to take my needle, it's going to go in plane with the actual probe here, and I'm going to come sort of right over the right side of the probe, my right side of the probe, sort of pointed towards the kangaroo's left shoulder. And that'll give me the right orientation so that I'm more likely to hit the actual heart. Obviously, I don't want to inject this kangaroo because then he'll die, and we love the kangaroo. But I think he lost pulses, didn't he?
He did. Compression, start compressions. All right, no, we're done.
Well done. So that's something procedural. The last little bit of teaching that we're going to do before the great race, which is what it's all about, is my little bit of procedural. And we're kind of running out of time, so I'm going to halve that And I was going to talk about Colles fractures because, pericardiocentesis is important. You do it often, emergency pericardiocentesis. But radial fractures, I look after every day. And I was going to talk about how to do an ultrasound-guided nerve block, which I'm just going to skip over. But if you happen to put the probe onto the axilla, this is what it'll look like, because I have to get through these. There's the humerus, there's the biceps, there's the triceps, axillary artery, veins, okay? And then nerves, musculocutaneous out there, radial, median, ulnar. And what you're going to do is pop your needle in, inject, pop your needle, inject, pop your needle, inject, pop your needle, inject. It's quite easy, it really is. But we're not going to talk about that. Instead, I'm just going to do the last bit because I've only been given 2 minutes. And I think pulling a fracture straight under ultrasound is really useful. So this is what, now we've got the wrong ultrasound machine projected.
Oh,
sorry. That's all right. No, it's all right. You keep scanning where you are. Okay. I'm sure we're on. Okay. So here we're looking at the distal radius. Okay, a nice flat line. There we go. And the end here, Lister's tubercle there, and then going over. And you just look for a fracture here. Okay? And then you pull it straight. We've already seen some fractures, and I'm going to show you some examples in a minute. But people start doing this on kids, and that can be a problem. So this is how you do it in a youngster. Can we just go to plain PowerPoint, please? So here it is in a youngster, and here it is. But you've got to remember that this is all cartilage, and this is a little ossification centre. And as the child gets older, things change. So this is what their X-ray looks like. And when that there is the cartilage bit. So it is all solid. Now, as you go and do an ultrasound, this is the same kid. That's what the ultrasound looks like. Okay? So an X-ray, and then you just pop your probe on, and there's the ultrasound. It's pretty cool, hey? That's pretty easy. So when you're 2 to 3, you've got a small ossification centre. As you get older, it gets bigger, 4 to 5. And then older, even bigger. Here you can see a little buccal fracture, okay? As you get older still, it gets bigger, and that becomes more like a fracture, that line, and that's what I don't want you to get wrong. Here you can see this very thin epiphyseal plate there, okay, that people may think is a fracture. So you've got to just keep that in mind. But when you do find a fracture, take a picture of it before you pull it, and then pull it. And before you put that plaster on, just check that it's in the right place. Here's another one, and we do it all the time. Obvious fracture here, here's the end. Pull it straight, have a look. There it is. If it's not quite, have another pull and have another look. Easy procedural ultrasound. What's the consequence in doing it? Nothing, you can't really make a mistake. Pericardiocentesis, make sure you've done a few other needles first. All right, that was that bit of procedural. And we're ready for the great race.
Yep, so you stay there.
Now we need a minute of setup. So while these guys set up, I'm going to explain what the great race is. There are 3 events. The first is where we have it in 2 bits. It's a relay. First, the Australians, there'll be a time, you'll see how long we take. Then the Americans try and beat our time. The first of our events is one of our selected candidates will do an eFast scan as fast as they can, and we will commentate on it, telling them when they can go to the next view. Okay? Should be quick. The next event is procedural ultrasound. Our next candidate will have to do some procedures. So can we have the chicken breasts and the jelly on stage, please? So what we've got, again, we've got some chicken breast and jelly here. We're going to get it all on, actually half of it on stage, that's fine. That's all good. Bring it out. What we got is we've got, thank you, a chicken breast with a little balloon in it. It looks like a blood vessel. These guys have never seen it before. They are going to, under ultrasound guidance, aspirate that balloon. Okay? So that's procedural. And then when they've done that, hidden in this big tub of triple strength jelly and Metamucil, which everyone makes in their rooms in Jupiter's.
So these are the ones for us.
Should have seen the looks.
Yeah, jelly in Jupiter's usually different reasons, are there, John?
Hidden in here are 3 balloons filled with fluid glued on the bottom. And Tor Oakley and I shared a room. When we ordered a lot of jelly, we did, and lots of raw chicken. It was strange looks. Anyway, what these guys have to do, having aspirated the vessel, is aspirate these balloons. Once they've done 2 of the 3, that's fine. Okay, so the second event is procedural. Then the third event, we're going to get a more difficult patient to scan. So if we can, we've got it ready to go. So not yet. Once we've done these 2, then the experts take over. And the first thing that the expert has to do, the first one, is to get vascular access, not looking at the ultrasound screen. So I'll put a needle into a vessel while Adrian guides me, but I'm not allowed to look at a screen. Then he gets blindfolded. And he has to do an EFAST scan on a patient who's more difficult to scan under my guidance. And that's our race. We time it, and then the guys from the States do the same thing. All right? How are we going? We ready? All right, team.
So we're going to start the clock when you guys are ready to go.
Do we have blindfold around somewhere? We just got to have that so that's not far away.
I got a few in my bag I can apply.
All right.
The blindfold, not the full mask.
As long as there's a blindfold around.
Yep, blindfold here.
Okay. I'm going to do some pointing with this. Get jelly on. Oh, we're being pre-prepared. Okay. So we're going to have a screen, the triple screen, with ultrasound and camera, or double screen, sorry, ultrasound and camera.
The clock would be good.
There we go. Oh, if there's a clock, that'd be good. If we can't get a clock on there, Lewis, every 15 seconds, I want you to say how long it's been.
Okay to heckle.
You ready? We've not got a clock. It's coming.
Call that hand position, huh?
Okay, so they can't see the clock. I can see the clock. Can we turn that round? Is it possible to turn that round? No?
Oh, no, that's okay. We'll start.
You're gonna just call it every 15 seconds. Okay. On your marks, get set, go. All right, right upper quadrant view. Liver there, kidney there, fanning right through. I'm happy there's no black stripe in there, no free fluid. Let's move on. Left upper quadrant, spleen, nice work. Kidney there, no black line in there. He's fanning nicely. Okay, pelvis, transverse. Okay, there
20
we go.
seconds.
Fan all the way down, all the way up. Nice, no free fluid. Let's go longitudinal. Right from the left, right to the right. Beautiful. Subcostal.
30 seconds.
Okay, no fluid around that at all. There's the right heart, left heart, liver, no fluid. Let's go IVC. Sorry, I'm going to throw an extra one and make it tough. Excellent. Well filled.
Oh.
All right.
45 seconds.
Okay, now we're on to lung. Change your depth. We can see lung. We're looking for sliding. He doesn't know where depth is. Someone else's machine. He's doing fabulously well. There's that sliding lung. Let's look on the other side for that final one. He doesn't have a pneumothorax. Let's move on.
Okay.
All right.
56 seconds.
56 seconds. All right, now we're on to vascular access. Now, what we're going to do is change the ultrasound to ultrasound, the other ultrasound machine up here, please. Okay, you're on. Go for it. Okay, we can see a black tubular structure. Okay, we've got a needle. It is going in. Here it is. We can see it. It's going in the right way. I'm excited. Come on. Has he aspirated yet? Oh, he's got green stuff in that syringe. That means he's in and the vessel's disappeared. All right, come on. Let's keep going. Keep going.
25.
All right. Okay, it's going to be tough. All right, let's see if we can find that. Change your depth. Make it deeper, guys. All right, we're now looking. That's the bottom of our bucket. Search for a balloon. I can see something here. All right, get it. Let's see. Get it, get it, get it. Have we got anything? Nerve-wracking, isn't it? Oh, he's got one. Okay, he's got one. Now find the other one. Keep
Minute
looking.
30.
Keep looking. Find that other balloon. Where could it be?
Good job. You're 7 minutes. 8 minutes, 9 minutes.
There we go. Okay, we've got a second balloon. Find it, get back in the middle of your screen. Needle in, and he's got to be in there. Well done. All right. Now, I take over. Hey, how come we get the small balloons?
That one.
That one.
Yep.
All right, let's do it.
Okay. Screen goes away.
Okay, this is going to be interesting. All right, can I have an ultrasound probe? So tough without an ultrasound probe. All right.
So you're going to look away, James. Is that right here? Tell us
I
what
can't
you're
see
going
a
to do.
screen. The screen's facing
Good.
the opposite direction. Okay.
Okay,
Tell me-
so scan.
Start.
Yep. Move your probe slightly to the right. Good. It's in right in the middle. Go in. Move your probe back to find your needle tip. Keep moving back. I can't see your needle tip yet. There we go. Right. Move your probe forward. Keep moving your probe forward. Move your probe forward. I'm still too far. Keep your needle still. Move your probe forward. Keep going. Keep going. Move your probe forward. Keep going. Probe forward. Keep probe forward. Keep probe forward. Right now, advance your needle. Aim it slightly to the right. Good. Yep. Advance. Probe forward. Needle forward. Probe forward. Needle forward. Slightly to the right, and you should be just about to puncture. Okay. Move your probe forward.
We're in. No.
Probe forward. Yep, you're right on the edge of it. You just got to point a little bit to the...
Okay, we're in. Okay, good.
Okay.
Okay.
Right.
Blindfold
I need a
for Adrian.
Blindfold tip.
Blindfold.
Yep.
Okay. I can't believe it's got stars on it.
Okay. I need the
They're
probe.
the Aussie stars, aren't
No,
they?
it looks good on you, man.
Okay.
Okay.
Somebody needs to give me the probe.
Okay, there's the
Okay.
probe.
Righto.
Can you be a gel putter on her?
Okay.
Be generous,
Right.
boy.
Need some gel.
Okay, we're going to start doing an E fast. Okay,
Yeah,
can you
on
put it in
the
the right upper
probe,
quadrant.
please.
Come on. All right, right upper
Okay.
quadrant, go. All right, let's
Okay.
see. I want to change your depth. I'm going to press the buttons because you can't
Yeah.
see a thing. Okay, come down towards feet. Okay, come down towards feet a bit more. Fan backwards. Fan down towards the bed. That's good. Move the whole probe towards the bed. Go around, upwards a bit. Okay, fan medially. Fan, where are we? Fan distally. Okay, we're seeing liver here, highly echogenic. Probe down towards you. I'll change the depth a bit more. Okay, fanning down, bring towards your feet, and then move the probe up. So we're going to try it subcostal anteriorly. Okay, bring the probe down towards your feet. This is all echogenic, highly echogenic. We're going to fan. All right. We're seeing liver, we're seeing the edge of liver. Okay, I can't see any free fluid. I'm going to move on. Right, left upper quadrant. Okay, probe almost down to the bed. Okay, so this is a tough scan, guys. Kidney here. Big cyst in the upper pole of the kidney. Move the probe one rib space towards the head. Fanning here is spleen. We're fanning to and fro. There's no free fluid around that spleen. We've got kidney. I'm happy there. Let's go pelvis transverse. Okay, pelvis transverse. Nice bladder here. Beautiful. All right. Let's go long pelvis. No free fluid behind it. That's beautiful. Let's go to subcostal. Okay, subcostal, I'm going to change the depth till it's really, really, really deep. I'm going to get you to take a deep breath in, please. Can't see anything. We're going to try parasternal long. Okay, up to chest. Where is he? Okay, more gel. Can we chuck on some gel there?
You got it.
All right, put his hand. That's good. There, you got the gel. Okay, come down towards you. And we got heart here. Medial a little bit. We got heart beating away. Because we've got an abdo probe, things around the back to front. I'm going to call that just fine. Let's go on and look for lung. Correlate your findings clinically. All right, we're going to change our depth. Doesn't want to. All right, here we're looking, we can see sliding sign, beautifully done, other side. And we've got a sliding sign. We're done! Woo!
Beautiful work, guys. 4 stations in 5 minutes 45. Good job.
5:45, all right.
All right, how are we going here? Yeah, doing good. Yeah.
So this time we've got Matt and Pragati, right? Who's going first? Pragati, you're doing the needle in. Matt, you're going to do the scanning. Okay. Ready, set, go.
Looks good, perfect.
Nice job. That's perfect. Yep. Okay.
Turning through.
Yeah, and we're done.
quadrant.
That one's, I couldn't do any better myself. Next. Okay, there we go, yeah.
Transverse view, that's really good. Sagittal.
All right, we need to get a long view there. Yep, that's actually very nice. Bladder here, good. Yep, and this is all, yeah.
Subcostal.
Subcostal. Yeah.
Beautiful.
Oh, look
RV.
at that. Look at that heart. That is a beautiful. Hey, let's stop and talk about the heart for a minute. What my favorite things
Your
about the
IVC,
heart
actually really
is
nice
the-
work. That is nice.
Sorry.
Lung, decrease your depth. You want to use it? Yeah,
Yeah, a
perfect.
little bit less depth. We want to see some breathing. If you could just take a deep breath for us. There we go.
Good,
That's
nice
perfect. Yeah.
sliding.
Look at that
Other?
sliding. It's beautiful sliding. Some more comet tails there. Nice thing.
Beautiful.
Maybe
Let's
just
pop that
give me just a
vessel
little
there.
bit more depth. That was strong. I mean, give up top. That's what.
Wow.
Right.
So if you believe that was 35 seconds. Okay. Ready whenever you are there. Righto, Pericardiocentesis, away you go.
You see it okay?
Some gel might help.
Yeah, you can slide a bit.
There we go.
All the way up and down.
There you go. You got it. Beautiful.
Perfect.
There's your tip.
Sure, you want to
nice
advance your
trajectory.
probe so you see your tip.
Nice trajectory. You're right above it. So
Keep,
you're sliding
keep
your probe
advancing your
also.
probe. Slide your probe up, and then push your tip. You can always bounce the needle a little bit if you can't see it on the screen. Oh, looks like a
So
little
let's
collapse there.
bend your
Yeah.
probe distally, so
forward.
you're following that needle tip. Good.
Yeah.
There it is.
Nice.
We're getting ready to pop in. You got to return. Is that it?
Did you go through the back wall maybe? You pull back?
Too deep.
Yeah, pull back. Let's try to find the needle too. You can come up a little bit forward with the probe. Yeah, there we go. See, there it is right. Oh, look at that. Did you hit the plate yet?
So you're back. There you go. So if you're aspirating as you come back, you're
Yeah,
going to get
just
it
come back,
slowly
back.
coming back. You
Perfect.
can see it coming back.
There you go.
through the
Beautiful.
vessel. There you go. Nice work.
So that was a good demonstration, wasn't it? Follow the tip at all times.
Yeah. It's good to keep your eye on the tip, just the tip.
And if you do go through,
back wall.
pull it back a
Good.
bit. Works well.
Yeah, it works great.
There you
actually.
go. There's your
Unless there's
balloon.
an
Nice.
artery on the other side, and then it doesn't work so awesome.
You're almost there. Pop through. There it is. Beautiful.
Suck out the pus.
Another one.
Beautiful. Where's
Find
that
the other
other?
one.
Where's that other balloon?
There it is.
I reckon that's the same.
Is that the same one?
No, it's further along. Nice. Different color. Good work.
Same colour, interesting.
No, it's red.
That's
It's
yeah,
red.
that's good.
Yeah.
I'll give you that.
You mixed
Very
them.
American response. Nope, that's not the same one.
Mixed. Okay.
Not at all.
Turn the screen. When we
All right, well, just turn the screen. Matt, if you just want to go ahead and get that needle on there.
This
get
one?
some going. It's a hole in it, maybe. All right,
What do you see?
to the left a
Make it
little bit.
easier
So you
for
want
him.
to put it right in the right. No, to the other way. Other way. Where's your probe marker? Put your probe marker to your left.
This is my probe marker, right?
Is that your probe
it
marker?
lighting up? Yeah.
Oh, that is your probe marker.
There
It's
you go.
lining up. Good. All right, so you get your probe marker to your left. All right, so you want to move to the right a little bit. Good. A little bit more. Just a little bit more. Back to the left just a touch. Back to the right just a touch.
Come on.
Back to the right just a touch. Back to the right just a touch.
All
Good.
I'm
All
just
right, you're
gonna
in the
get
center. Go ahead and put your needle in.
Tip. See
Just
it?
the tip. Yeah, you're going to put that a little bit more to your right. So just go a little bit to your right. And then you want to go, I got a good tip there. Yep, maybe. Beautiful tip. Yep, move your needle forward just a little bit. Come back a little bit to your left. Good. Needle forward just a touch. Good. Keep going forward with the needle. Got your needle in view. Good. See your needle well. Good. Keep going forward. You got your right over the vessel. I can see you tinting
There it
the
is,
vessel.
got it.
If it work.
Nice work. Okay.
It's a blindfold.
Is it on?
Yeah, you might want to wrap it around again. I can see some stuff. Oh, it's tight. Australians are brutal.
Rich is over here, Mike.
Hold on.
What's
Hold
the
on.
time? How are we going time-wise?
Can I get a probe?
Do this for you.
Reg volunteered for this. He
Little
wasn't
bit.
sure about this
There
stuff,
we
but
go.
anyway.
All right, I got a probe.
Right.
Are we ready?
There you go.
Yeah. All right.
Yep, that's the right way around.
You got 3 minutes 10. Remember the time to beat. It's just over 5
Dawson, you gonna
minutes.
talk to me?
Yeah, not yet. We're increasing your depth.
Oh, that's a good idea.
All right, so down, your inferior. Slide down, good, slide down. All right, more anterior, slide up the body, good. Now slide a little more inferior with the eye. There you go, liver. Good. Now just fan back a bit. There's kidney, beautiful. Just fan through that slowly. Now slide down a tiny bit more. I want to see the tip of the liver. Beautiful. Left upper quadrant. Go to the left. Further back. It's always further back. There you go. Now stop.
Nice.
There it is. You got the kidney there. You got spleen, kidney. Fan through that slowly. Slide up a tiny bit just so we can see suprasplenic if we can. When we got lung in that. Where'd you go? Wrong way. Superior on him. We saw the splenorenal recess. We're just trying to see above the spleen if we
3
can
minutes
now.
50.
That's fine. Good. Perfect. Bladder. Go to the bladder. It's going to be inferior to the umbilicus. Yeah, there you go. Perfect. You got a transverse, fan through it. Now turn sagittal. Good. Fan left to right, all the way, other way. No, all the way, the other way, all the way, the other way. There it is. Perfect. Subxiphoid. Come on.
14.
There you go. Flatten. Good. Perfect. I'm just going to increase your depth. Good. Just fan through that just for fun. There you go. All the way. Yeah, great.
Can we talk about the heart for a minute?
Lungs. Come on, focus.
4 minutes 30.
There you go.
You got 50 seconds to beat them.
Stand still. What are you doing? Just decrease, the depth won't decrease. We can see sliding.
Like 15 seconds.
The depth's not decreasing, but I see sliding. Good. Left side. There you go. Now it's decreased. Good. Beautiful sliding. Go back to the other side just so we can see it again, zoomed in. Nice. You see him breathing there.
450. Clock's ticking. You're done.
Done. Nice.
Beautiful work, boys. Thank you very much. Can we just have a hand for Reg here? Thanks, guys. Thanks, Reg. And before we have Graham, stand up, Graham. Fantastic. Thanks for being a patient today. So now it's decision time. It's going to be fast. So we've got a quicker time by our US friends here. But then we've got to then decide, do we just go on the time or do we go on the teaching skills and messages they've given us today? So let's have, the time was quicker for the US. The overall picture now is decide to vote. We can't really decide any other way except you guys deciding. So, why don't we go the Australians first? Let's have a hand. Who thinks Australians won today? Now remember, we've got some US visitors here. Let's be polite. Who thinks the US won? Good.
Good work, gentlemen.
So I think we have clear winners. Can we have our US team over here and the winners of that?
Nice job.
Good work. Well done. Fantastic. Thank you so much.
So Matt and Praggity, $500 to the next SMAC conference. Nicely done, Roger. I'll make him come back. So Matt, well done. Praggity, well done. You guys, you just get our eternal thanks. Mike and Matt.
Hang on. There's a book from...
Oh, yes. And Sue Davies is going to present something here. Everyone knows Sue. She is Miss Gold Coast Ultrasound, Australian Institute of Ultrasound. And for them, they get Benita Anderson's book and Benita Anderson's other book. And to our runners-up here, to Tom and to Kim, a $250 voucher for the next MAC conference. Thanks, guys. So that's just about it. Thank you very much. One of the ways we think we should all learn now is something called asynchronous learning. Learning anywhere, in any way. I think you'd agree that's about as asynchronous as it gets. And we're very delighted to have these guys here. And one of the best things about coming to a conference like this is you get to spend time with wonderful people who really are experts in their field. And I think we've been absolutely honoured to have today. We've had Matt Dawson, Mike Mallon, Adrian Gowdy, and James Rippey. Can we say thank you very much to them? Let's thank Matt and Praggity, and we've had Tom and Kim, our qualifiers as well. Up in the desk, we've had Grace. Grace Leo, our medical student, has done so much work getting all the music together, and Roger's been up there working that as well. Sue Davies, we've had Reg and Graham, who have been our models. We've had our medical students, driven by Laura. Thank you, Laura, for Matt and for Kyle, who've done a lot of work to get us all together here today as well. And of course, our friends from Philips supplying the machines and the qualifying. And then finally, I think there's a person whom we should mention specifically, and that is James. James Rippey, he's the crazy guy who coordinated this all together for us. A lot of people spend their time reading from the menu rather than enjoying the banquet. And I think James really has shown us how to enjoy the banquet that is critical care ultrasound by his enthusiasm and willing to teach us all. So thank you again, James. It's been fantastic. It's been a lot of fun. You've been a wonderful audience. That concludes Sonowars for 2014. Thank you and good evening.
So I was amazed at Sonowars by a couple things. First off, the competitors were unbelievably smart. We were shocked by their knowledge and skills. And James, Adrian, and Lewis were incredible to work with, all three such class acts. So if you want to be part of this, come to SMAC. We'll be having qualifying for the competition at SMAC this year the same as last year, and it will be just as fun and hopefully as educational. See you at SMAC and hopefully the week before in Yellowstone as well.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.